Okay, perfect. So my afternoon report, just give me 1 second. There we go. So it's about an 84-year-old male with an unknown past medical history besides heavy alcohol and tobacco use. He was brought in by EMS after being found down at home for an unknown amount of time. Oh, there we go. So most of the history was obtained from the daughter, but the patient had been complaining of bilateral lower extremity and scrotum swelling associated with shortness of breath for the past week. She visited him 3 days ago, hadn't heard from him, went to his house and found him down on his bedroom floor for an unknown period of time. Per EMS, the patient was lethargic but arousable, hypoglycemic to 30s in the field. He got dextrose without improvement in mentation. At baseline, he's ANO times 3, lives alone, and is independent in ADLs. And of note, patient doesn't routinely follow with a primary care doctor, doesn't really get evaluated by a physician. So a lot of the components of the history are quite limited because it was difficult to obtain collateral from the daughter. She says a lot of things weren't discussed within the family, but we know, like I said, unknown past medical history except alcohol and tobacco use. Per daughter, no past surgeries, unclear family history, but we do know that he lives alone, has 2 daughters, 1 estranged, heavy alcohol and tobacco use for 30 plus years, but unclear quantity. So per daughter, he doesn't take any medications and none were documented in the EMR, and no allergies, and really unable to obtain an ROS from the patient given his mentation. But we do know that there's shortness of breath, lower extremity swelling, scrotum swelling, and lethargy. So on arrival, the patient was persistently hypothermic to 30 Celsius or 86 Fahrenheit. He was fairly normotensive, 120s over 80s, no tachycardia, mildly tachypnic, 16 to 21. And we weren't able to detect a pulse ox on him, likely from the significant hypothermia causing peripheral vasoconstriction to allow him like internal organs to keep warm. On exam, he was ill appearing, had a right eyebrow laceration, irregular rhythm, but normal rates, had a bilateral decreased breath sounds at bases, scrotal edema, but no testicular masses, diffuse anasarca, cool to the touch. He had a stage 1 sacral decubitus ulcer, but no overt signs of infection. He was obtunded, opened his eyes to verbal and noxious stimuli briefly, withdraws all extremities to noxious stimuli, doesn't really follow commands, but protecting his airway. So does anyone want to say any key history or key physical exam findings?
And also if you have any questions, if you can actually go back to the HPI slide, Sidra, just to see if anyone has anything else that they want to ask or want to know about the patient.
Oh, there we go.
Do we know if he has like previous hospitalizations for like alcohol intoxication or like seizures due to alcohol withdrawal?
No, this was his first hospitalization in the record and no alternative MRNs, unfortunately.
Good.
I can't see the chat just in case anyone's putting that in there, but.
Yeah, I'm keeping an eye out for the chat. Does anyone want to know anything else about the physical or anything else?
How old was he again?
He's 75, mid 70s.
Okay. Has he traveled recently anywhere or had any long car trips, airplanes?
No.
I take it you're thinking about a PE there, Catherine, or why?
Yeah, hypoxic, found down.
Well, we really haven't confirmed the hypoxemia either. It's just, I believe that it wasn't been able to detect by the pulse oximeter, partially probably because of the severe or the significant hypothermia rate. Probably a lot of vasoconstriction there. But good thought. Okay, so if we don't have any questions, just Patricia, or well, Abhinav is asking last well known 3 days ago, right? Just confirming, Sidra.
Yeah.
Okay. So Patricia, do you want to help us with the summary statement?
Sure. Middle-aged male with unknown past medical history other than alcohol and smoking history. Found down at a home and brought into the ED, found to be hypothermic and tachypnic. Only kind of like history, it was swelling of bilateral lower extremities and scrotal swelling. And on physical exam, found to have irregularly irregular rhythm and like the anasarca
Okay.
and
Yeah.
altered status.
Okay. And I think we've had this discussion before, but you said middle-aged, right? How old is he, Sidra, again? You said
I said
70?
no, elderly, 70
Oh,
something.
elderly? Oh, okay. I thought you mentioned middle-aged. Yeah. Okay. So yes, elderly male, signs of hypovolemia you mentioned, lacerations. I would add also that what Avinav was asking is very important when someone is found down, just the last known normal 3 days ago. That's definitely something in there that I would add as well. Sidra, can you show us your summary statement?
Yeah, so we have an elderly male, unknown past medical history except heavy alcohol and tobacco use. He was found down last known normal 3 days prior, found to be hypothermic, tachypnic. He's ill appearing, obtunded but protecting his airway. He has signs of hypoperfusion, head trauma, volume overload, and possible arrhythmia. So does anyone have like a differential diagnosis, or is there anything people would want to order?
Get like a TSH.
Okay. And why would that be?
I mean, it could be like a myxedema coma. He's hypothermic, he's swollen, arrhythmia.
Yeah, great thought. And the altered mental status as well, right? So Nobel, you sent the shotgun text, CBC, BMP, UAU, tox EKG. Could you just tell us your general thoughts on that for the work?
To find out any alcohol or any drug abuse, and also serum alcohol as well. An EKG arrhythmia to exactly find out what sort of arrhythmia is going on. And CBC-BMP just to find out any electrolyte disorders for this encephalopathy versus altered mental status.
Great. So yeah, definitely. So CBC, you can check for an infection. I don't know if you mentioned that. BMP, definitely lights, something that can cause like altered mental status. UA, same, you can like screen for infection. UTOX, great thought. And EKG, arrhythmia. Bailey is saying belly labs. Anything specific about like belly labs, or what do you mean by that, Bailey?
No, I just think with like an elderly male found down, altered, like when you're elderly, you're like a lot of infections in the belly can cause altered mental status, and like you're less likely to have the normal symptoms of like abdominal tenderness. And obviously he's not able to tell us anything. So you might as well just check them just to be sure if you're not going to CT the abdomen and just the head.
Okay. And any labs in particular that you were thinking of with the belly labs?
I guess like just LFTs, lipase. That's really the belly labs.
Yeah, I think LFTs in particular might be useful for this patient as well, given his history of alcohol abuse. Could be long-standing, is all we know. Potential, hepatic encephalopathy as well. That's a really good thought. Jen is saying TTE, probably because of the physical exam findings. Also hypothermic, definitely concerning for CHF. Bailey, I see you also said VVG. So any reason why you want to get that?
Obviously we just did a a whole lecture on it, but there's so many abnormalities that could result from his, I guess, downtime, his altered mental status. He's elderly again. And then you would want to see lactate, like maybe he had a seizure and then like just was like postictal, unable to get himself off the floor after. So that would just be helpful.
Perfect. The only thing is in this particular case, since it might actually be useful to get an ABG, I would say, because, like we weren't able to get a pulse ox. either, and the patient is tachypnic. So it's something I'd want to make sure that like the patient is well, oxygenated, but that's a good thought. A VBG would have been sufficient if I guess you were thinking about hypercapnia as well, or if you wanted to like, get a VBG with lactate if you're particularly worried about lactate. I know you mentioned you were worried about a belly infection, but in this case, it might be a good thought to fully check with an ABG. Catherine, I see CT head, check for intracranial bleeding. It's something we saw laceration after being found down, right? We mentioned he's an elderly gentleman. I think it's a good thought. We don't know his prior history that well, but definitely something concerning. Catherine also saying CK for rhabdo. Again, after being found down for at least 3 days, it sounds like. I think that wouldn't be an unreasonable thought. I think Sidra also mentioned he had a stage 1 ulcer in his back, so he's been down probably for some time. And venous, trope, BNP. I guess definitely before that, I would probably get the EKG, or well, really all these things, we get them simultaneously. But BNP definitely with that physical exam, trope, yes, that would be okay, but like definitely getting that EKG as well, just to check out like the differential of arrhythmia as a potential for being found down. So okay, so these are all good thoughts. I know we also mentioned TSH. I think we've covered most of them. And one more thing, I guess, that like is very important and we didn't cover before we go into the discussion, but this patient is hypothermic, right? Tachypnic, this patient was found down. One of the differentials of everything that you asked were, an infectious etiology. So definitely like a blood culture is something that you could be thinking about. It's something that we didn't mention. And again, since these things are, when you have a patient that is found down, like these things happen in parallel, that is something that I would be thinking of if I'm already drawing labs. So Sidra, if you want to go ahead. And yes, okay, so as of now, I'm gonna take over for just a little bit. Give me 1 second. Okay, so basically I just wanted to talk a little bit about, what to do with this typical presentation of a patient being found down. It is, as you guys can see, it has a very broad differential. It is sometimes a little bit hard to, wrap your mind about what you have to do when you find this patient. This is something that will typically be seen more frequently in the ED, but, you will also commonly receive this patients on the inpatient side once they're admitted and the differential is still being worked up. And additionally, sometimes you will find patients down in their rooms, like you'll get, rapids as an AC for those of you who are going to stay with us until 3rd year. And even when you're an intern, sometimes like it may happen that you find your patient down. So just wanted to go a little bit about, how to work this up, how to manage these patients. So I think I'm going to talk a little bit about, history, examination, differential, and workup. So just in terms of the history, I know Sidra talked a little bit about kind of how to do it, but how exactly would you go about, getting a history in a patient that's been found down?
Go to a family member, try to figure out last time it was okay.
Collateral, great. So family member, we talked about last found down, or last normal, I would say. Definitely extremely important. Is it just a family or anything else? As an intern or a resident, once you see this patient in the ED, is there anything else you can do?
EMS.
EMS, yeah.
EMS.
Sorry?
People.
Oh, EMS,
EMS,
yes,
yeah.
perfect. So EMS, many times the ED might straight up tell you, this is what they told us. But even if they don't, normally either on Epic or on their chart in the ED, you'll be able to find a brief report from EMT. And sometimes you can actually find information that might be pertinent for the history there. So what are some things that may be important, from EMS who found the patient down?
Like Did they found any medicine on the scene when they went to see the patient? Did they found any blood on the scene when they went? What was the situation of the room when they saw the patient?
Excellent. So yes, pretty much many times, and if you deal with a case of like intoxication, they'll tell you, maybe like the patient was reeking of alcohol and like a bottle was found, or maybe like a specific medication was found, empty right next to the patient. So these things are important, and like you said, blood or other things that were found there, it's very important. And a little bit more obvious, but just straight up like the past medical history. Someone asked in the chat, has this patient been hospitalized before? Like, can we look at the records, or is there something on Health Everywhere? Does the patient have a PCP? I know Sidra mentioned in this case he doesn't, but those are other things that when we don't have collateral, like a family member to provide a little bit more of a history, this is something else that we can go around chasing as well. So that's basically some of the most important things that you can talk to or you can get from the history, or how to go about the history. Now, in terms of the physical exam, so what do you think it's important to assess in like the physical exam once you get to a patient that is found down?
To expose the patient completely.
Okay. I would say definitely, yes, full skin exam.
Yeah.
And exposing the patient completely. They've been down for a while. Here we find an ulcer, but maybe you can find even like neck fash. You can find like maybe fourniers gangrene that you wouldn't be able to notice unless you fully examine the patient, especially if they're not verbalizing stuff to you. And also lacerations. Maybe a hit in the head might be missed if you don't like actually go looking around for it. So that might definitely change your differential. But I would say before anything, it's going back to base. Sorry, you said what?
Vitals.
Vitals, very important. Definitely here. So we saw the patient was hypothermic, tachypneic, couldn't really get a pulse ox, but that is, if you're in the hospital setting already, or the patient is coming to the AD, definitely you want to make sure right away that the patient is hooked to a monitor. And part of this, going with vitals, I would say, like the ABCs, right? So you find a patient that is found down, the first things you need to do is check the airway, how the patient is breathing, and does the patient have a pulse? Like these are things that you need to ensure right away. And I've said this multiple times before while talking about this. This is not necessarily that you'll do one over the other. Most of the times, or most of these things might happen simultaneously. But definitely ABCs is extremely important in this case. What else? I think, so being found down as part of the terminology, we're kind of talking about an altered mental status, right? So the patient is being found down with an altered mental status. So you can actually, like, the neuro exam is extremely important. And especially like the mental status, like describing it is an extremely important. You might not be sufficient to say, ANO times 0. I think Sidra did a pretty good job here at saying, being specific when writing the note, and when assessing it. She was saying, this patient is withdrawing to pain, opening the eyes to pain. You can also write, is a patient tracking or not? So these are all pretty important things. Also with the neuro exam, do you see any signs of focalization? Right. So these are things that might point towards one differential or the other. And very important. But there is also another piece that is pretty important for a patient that is found down that I think wasn't specifically mentioned here. What do you think? And it goes kind of in line with the neuro exam. You'd assess this in the cranial nerves. So it's actually, give me a second, I actually noticed that I hadn't been, there you go, Jen. Yes, I stopped paying attention to the group chat for a little bit, I'm sorry guys, but yes, pupils. What can the pupils tell you, Jen?
Like meiosis, mydriasis, may relate it to toxin ingestion, like opioid overdose or some other illegal drugs like cocaine.
Yes, that is great. Definitely, you know, part of the toxidrome syndromes, the pupils are very important for that, and it's something that's emergent. You need to recognize it right away, and or it benefits a patient if you recognize them right away. And it's something that you have to assess. Not only that, but some signs of, you know, a mass herniation, if you see uneven pupils, or even if you see unreactive pupils that's, you know, stay the same size. All those things can tell you, you know, can tell you a lot of information in regards to like the potential differential diagnosis. And then as part of the ABCs, you know, definitely talking about, you know, the respiratory physical. So in here we see, you know, the patient is tachypnic. You can also see, you know, is the breathing labored, shallow, deep? All those things definitely can tell you a little bit more, you know, as a patient having wheezing. And I know it kind of goes full skin exam, but like definitely signs of trauma, I would say, very important. In this case, we do have the laceration, and well, I guess just applicable to this case, we found the patient edematous. So that might point you to like one side or the other. So talking about the summary statement and what we were talking about and trying to put the history and physical together, that will later help us come with get to a differential diagnosis. We find an elderly gentleman that was found down approximately 3 days ago, has a history of alcohol abuse, no known medications. That's very important because, of course, some medications might be a cause of the differential. Find tachypnic, hypothermic, and withdrawing to pain. That's kind of his status right now. And I would say like signs of hypervolemia. So that kind of all this physical and history will start pointing us to the differential diagnosis. So when it comes to the differential diagnosis, like I said, it's very broad and there's many different ways to do it. I think one good way to put it into like buckets is just think about it as like brain or neural causes, then metabolic derangements. Then even though like some might group it with metabolic derangements, I like to think about toxins separately. And then, you know, you have the ruled out causes of like psych disorders or malingering. So in terms of neurological causes, can anyone think of the differential or important differentials in general just to rule out in this patient? Or some of the more important ones. So Patricia is saying stroke, definitely. That's something that you have to think of right away, especially with like particular history. And remember, it can be both ischemic or hemorrhagic. In our case, this patient has a laceration. He is elderly. So that is something that you can think of and potentially go over. And just for the sake of time, you know, I'll go over a few more. So you can talk about like mass herniation. You can talk about infection, you know, abscess. You can talk about anoxic brain injury. So in this case, I mean, I'm definitely worried, thinking like, is he even perfusing okay with that hypothermia, like that hypervolemia? We definitely have to check his heart function. And of course, you also have seizures, right? Could this patient also have had a seizure? You know, syncope, less likely he would have recovered, but that's part of why the downtime is important to tailor you towards a specific differential diagnosis. And so that's one bucket again. So the other one that I mentioned is just metabolic derangements. So what are some, we already discussed about some potential differentials that he would be at relatively high risk for, right? Can anyone mention some? And starting off, of course, with hypoglycemia, which this patient was found to have significantly so. What are some, I mean, we asked for the BMP, we asked for all those labs. What are some derangements that could cause your patient to be altered?
Hyponatremia.
Mm-hmm. And that's both, right? So sodium, both hypo and hyper can give you altered mental status. So Patricia is saying hypothyroid. Definitely, like we talked about hypothermic, edematous. So endocrine disorders, I would say, like just in general, adrenal abnormalities could also potentially cause a similar syndrome. Cheryl is saying hypercarbia, great. Hypokalemia, bradycardia, great. So in general, so I think that I would have put it, or the way I think of it, not that you're right or wrong, Tom, but in my head and the way that I think of these buckets, I go that into like anoxia to the brain and like poor perfusion, but definitely hypokalemia can end up being a cause of altered mental status. We mentioned hepatic encephalopathy, which this patient is at risk of course. I would say even uremia as well, if altered mental status and poor renal function. And I think we had already mentioned the blood cultures, but this is kind of, you can also have septic encephalopathy, right? And I'm sorry if you can't read my mind, but this is kind of way I think of it of septic encephalopathy as a metabolic derangement. And calcium is another hypercalcemia, bone stones, bones, groans, psych overtones, I don't know, many owns, but that's what can be caused with hypercalcemia, so not to forget it. And then, so those are the main ones. And so the next one that I was talking about was toxins. We had mentioned a U-tox as a differential. So definitely, what are some intoxications that could potentially cause this? For the typical ones.
Like overdose on like heroin.
So opiates, great. So that's something that, like, again, you look at from the ED maybe, or the history, or if they're hospitalized, sometimes you might find your patient down and then like you need to do your own medication review, right? They might be a cancer patient who's been receiving like a sudden high dose of opiates that were miscalculated. That can happen, so definitely. This patient has this past medical history. It's his only past medical history. What else could cause this? So ethanol, right? Ethanol, definitely, even like benzos as well, kind of in line with ethanol. And I would say that goes both ways. They can also cause seizures with withdrawals, right? And even sometimes like non-convulsive status could end up happening on the neuro side. But definitely some things to think about. This patient is hypothermic, but if he were hyperthermic, so serotonin syndrome, neuroleptic malignant syndrome, and yes, I think those are the main ones. But in general, like keep your differential broad, like GHB, another one, and then you have like these until you rule out everything else. But psychosis such as malingering, and the psychiatric coma. So we talked a little bit about the differential. Now talking about the workup, we talked a little bit about what workup would be appropriate in this patient. And so we talked about blood count, and I would say in this case cultures, since the patient kind of like was hypothermic, there might be suspicion for sepsis. We talked about BMP, LFTs found down in this case, and if you're worried about hyperperfusion, shock liver would be something. And in this case, hepatic encephalopathy with a history of alcohol use disorder. Depending on the history and medications, you might check coags. UTOX, we already mentioned. Anything else that you would want to get? So we mentioned ABGs, or ABG in this case. CPK, thank you, Patricia. Definitely something that would be appropriate here. And I would say as part of the workup, sorry, I forgot to add here calcium as well, I would add. It's not included in the regular BMP. Novell is saying CT head. Yes, so your thresholds should be relatively low depending on the patient. In this case, elderly gentleman found with a laceration after being unknown down. Definitely something that I would consider, especially if they are taking antiplatelets or anticoagulants. That's might point you more towards one direction than the other. And here I would just say, this patient was like, didn't have a detectable pulse ox, has a history of alcohol use disorder, is hypothermic, is found down. That is something that I would consider getting as a regular or a basic just infectious workup. And I think we got most of this. More pertinent, oh, forgot to mention like TSH, endo, right? Depending on the presentation, you might want to do that workup. If already inpatient and you haven't found an etiology, some other things that you might start thinking of are LPs, MRI if the CT head didn't show anything and you still haven't found anything. EEG, like I mentioned, like non-convulsive status epilepticus is a thing. And of course, the way you start with this workup, it's some things you might do at around the same time. Another thing I forgot to mention, sorry, was EKG, but basically a point that I want to make is like when being found down, you do need to consider the timeline or the differentials, meaning you're not going to want to rule out non-convulsive status epilepticus first, right? Because that's not an emergency. That's not going to kill your patient right away. You need to kind of like tailor your workup as to what is urgent, what you can do soon after the patient is down. And I'm going to send in the chat actually a pretty good article talking about a patient being found down. Jackie had shared it with me previously, but it gives you a really nice time frame of just how the ED looks at it, because I feel like they look at it this way a lot more frequently than we do, but just giving a timeline, what is the differential that you need to rule out in the first 10 minutes, in the first, in the first minute, in the first 10 minutes, in the first hour, and kind of, I thought that was another interesting way to put it. Personally, internal medicine, I still prefer thinking about it broadly in buckets, thinking you're going to see this patient in rounds, but this is another way to approach it when you see the patient found down. And as part of the workup, besides the EKG, definitely, please do not forget glucose. It's extremely important, and just like I was about to miss it right now, it gets frequently missed in rapids. Do not, that is something that you can check right away with a finger stick, and it is a common differential and a reversible cause that could be potentially life-threatening. So there you go, that's it, and we can go back to the case.
There we go. So these were the labs. So no leukocytosis. The PMN count was a little elevated to 86%. He had a macrocytosis, a thrombocytopenia to 80s. He had a coagulopathy with an elevated INR of 2.4 and a high normal PTT. He had a hyperkalemia, an elevated BUN and creatinine, but we don't have a baseline. An elevated CPK. All of the LFTs are elevated, including the T-Billy alk phos and a 2-to-1 AST-ALT. The lipase is normal. Since we just read a lot of acid base, I won't ask anyone to read this, but he has a respiratory acidosis with an anion gap metabolic acidosis with an elevated lactate to 3. And his PaO2 is 55, so he's hypoxic. TSH is normal, cortisol is normal, TROP is elevated to 0.116. The BNP is elevated to 900. The UA is negative for infection and no alcohol. So the EKG was uploaded to OnBase, so it's a really poor quality picture, so I won't make anyone read that, but essentially it's showing an irregular rhythm. There's no P's before every QRS, but the heart rates are controlled, so essentially AFib and also really low voltage EKG. Does anyone want to attempt to read the chest X-ray?
So Catherine, do you want to give it a try?
Sure. I mean, I think it's rotated a little bit underexposed, so it's not the best quality. It looks like on the left side, can't really make out the right side, can't make out the diaphragm that well, so probably some opacities, mainly at the right base, but Can't really make out the left costophrenic angle either.
Yeah, so that's good. So keep in mind this patient is laying flat, like laying down, and it is a portable. So he does have this large right pleural effusion right here. He has some cardiomegaly, and it's, like you said, really difficult to see the costophrenic angle on the left side. And you can actually, if you look enough, there's actually some fluid in the fissure here, so a probable left pleural effusion. And something interesting that I think looks cool is there's actually an air bronchogram right here. And that kind of correlates with a CT if anyone wants to try and read that.
So Bailey, can you tell us just what you see on the CT, or do you see anything in the CT?
Yeah, I mean, it looks like there's something on the, I guess, right side correlating to the, I guess, the pleural effusion. I'm not really sure what, oh, maybe that's, I'm not sure what that thing is next to, that has like the line going through it.
Yeah, so actually this is an air bronchogram. So an air bronchogram is when you have like, you can basically see the bronchioles and airways because there's an edentopacification behind there, a lot of times indicating a pneumonia. And then also, like you said, there are some pleural effusions here, really quite significant. And this like interesting, weird kind of stuff here is probably some bilateral atelectasis. Okay, and I'll show you now the reads. So the EKG, like I said, AFib with controlled heart rate. Chest X-ray had a moderate right pleural effusion with a probable small left pleural effusion and a retrocardiac opacity. The CT cap has large bilateral pleural effusions with the left upper lobe consolidation, severe bilateral atelectasis, cardiomegaly with left atrial enlargement, and moderate volume ascites. The CT head I didn't show because it wasn't a great image, but it actually had an age indeterminate trace right frontal and parietal subdural hematoma, but the CT cervical spine was negative. He had a POCUS at bedside that had a significantly reduced left ventricular function of 10 to 15%, left atrial dilation, a dilated and non-variable IVC, a large right pleural effusion and moderate left, and a trace pericardial effusion. So essentially we treated this patient as a mixed cardiogenic and septic shock with a likely cardiogenic shock predominance. So he was admitted to the MICU. His echo actually showed biventricular failure with a severely reduced EF of 10% and dilated cardiomyopathy. So we thought that he had suspected chronic cardiomyopathy, possibly in the setting of his alcohol use with an acute subacute event precipitating his decompensation, and that he was also having sepsis, likely a respiratory source with a left upper lobe pneumonia, possibly in the setting of aspiration while prone. When he got to the MICU, his blood pressures dropped rapidly. We placed a crash femoral central and arterial, and he was started on dobutamine and Levophed. He was managed with vancomycin and azithro and IV diuresis, and his subdural hematomas were stable on repeat CT heads. And then later in the night, he had a cardiac arrest with asystole, was intubated, and we got ROSC after 14 minutes. Pressure requirements continued to uptrend, and we eventually added vasopressin. But after talking to the daughter, although he was initially full code, she felt that he would not have wanted to be further resuscitated or intubated, and the decision was made for palliative extubation. So to go into the talk, I wanted to talk about how to approach a patient's volume status. So you always want to look for clinical indicators of hypoperfusion, and that includes tachycardia, tachypnea, hypotension, altered mental status, oliguria, and lactic acidosis. And whenever you have a patient with signs of hypoperfusion, you always want to assess for two things, and that's both cardiac output and whether the patient is hyper or hypovolemic. So signs of high cardiac output, you want to look for a wide pulse pressure with a low diastolic blood pressure, warm extremities, bounding pulses, and a rapid capillary refill. With low cardiac output, you'd see a narrow pulse pressure. They'll be cool with weak pulses, modeling of the skin, and delayed capillary refill. In hypervolemia, you may see JVD with a Kuhl's-Small sign or a hepatojugular reflux, S3 gallop, Rales, anasarca, P&D, or orthopnea. And then in a hypovolemic patient, they'll look dry, have flaccid tinted skin, sunken eyeballs. They may be tachycardic, fast 30 pulses, and orthostatics. So how do you predict whether a patient is fluid responsive? And what does fluid responsive really mean? It's actually the physiologic ability to increase stroke volume in response to a fluid bolus. So in other words, is the patient preload dependent or preload independent? And this is important to determine which patients fluids are going to be effective in, because otherwise they can just be detrimental. And being preload dependent and independent just really tells us where the patient falls on this Frank-Starling curve. So the Frank-Starling law tells us that preload is directly proportional to stroke volume. So if you have an increase in preload, you should see an increase in stroke volume. But depending on where you fall on this curve will dictate how much change you're going to see. So if you're on like a steep part of this curve and here you have preload and here you have stroke volume, when you increase preload, you'll see a significant increase in stroke volume. But if you're on a flatter part of the curve, the same increase in preload isn't going to affect your stroke volume as much. And you can see how the curve changes with heart failure and decreased myocardial contractility, in that it gets a lot flatter. And previously, we used to use static variables like central venous pressure to predict fluid responsiveness. But per the Surviving Sepsis campaign, also endorsed by the American Thoracic Society, they recommend dynamic over static variables. And those include pulse pressure variation, IVC variability, and a passive leg raise. So we all know that pulse pressure is equal to systolic pressure minus diastolic pressure. But it's important to know how to read that on an arterial line. So you have the systolic phase where the left ventricle ejects, you have the dicrotic notch where the aortic valve closes, and then you have this diastolic phase where the blood just runs into the peripheral circulation. So your systolic and diastolic, so your pulse pressure is going to be the difference between the top and the bottom of the curve. So pulse pressure variation is a little bit more of an not accessible method. You have to have a mechanically ventilated patient with an arterial line. But essentially, a patient will be fluid responsive if you see a wide variation in both their pulse pressure and their systolic pressure during respiration. So specifically, pulse pressure variation greater than 13% and a systolic pressure variation greater than 10%. And the idea behind this is that someone who's going to be preload dependent or fluid responsive, their pressures are going to be affected significantly by the changes in venous return and thus preload that occurred during respiration. Whereas a non-fluid responsive patient, their pressures aren't going to be affected as much. So when you look at the arterial line, you're going to see the systolic pressures rise and fall, and then you'll see the pulse pressure increase and decrease as they go from inspiration to expiration. Another more accessible method is IVC variability. So you can just do this bedside POCUS. You don't need to be mechanically ventilated. You don't need to have an arterial line. And you essentially want to look at the IVC where it runs into the right atrium, just distal to the junction between the hepatic vein and the IVC. And what you want to look for is more than 50% variation in the IVC diameter with respiration. So in spontaneous respiration, you inspire, you decrease intrathoracic pressure, and it's almost like a sucking effect on the IVC to increase venous return to the right side of the heart. And so you'll see the diameter decrease, and then on passive expiration, it should resolve. So that's the idea behind it. You can also look at compressibility, and per guidelines, a dilated IVC is greater than 1.7 centimeters. So if you remember our patient's POCUS, he had both a dilated and a non-variable IVC, so he was not fluid responsive. And then last, you have passive leg raise. It's also kind of the same concept, but you basically sit the patient upright 45 degrees and then lay them back all the way flat. And essentially, you're just transferring the dependent blood in the legs from the legs to the abdominal compartments, increasing the venous return. And in a patient who is fluid responsive, you should see a more than 10% increase in their pulse pressure. So it's essentially like giving a 500 cc bolus challenge to a patient and seeing if they tolerate it. And if they don't tolerate it well, you can actually just reverse it and have them sit back up. So what is shock? That's my little picture of shock. So it's an imbalance between oxygen delivery and oxygen demand, which leads to tissue hypoxia and hypoperfusion and end organ damage. So it's easy to think about shock when you think about this equation. So basically your ability to perfuse your organs is dependent on both cardiac output and systemic vascular resistance. So you're going to see a decrease in your map if you either have decreased cardiac output or decreased systemic vascular resistance. So if you have decreased cardiac output, you see that in 3 types of shock: hypovolemic, obstructive, and cardiogenic shock. And when you have decreased systemic vascular resistance, you're going to see that in distributive shock. So I made this little diagram to kind of help approach and differentiate shock. It is a simplified way of looking at it, but I feel like it helps kind of create a foundation on how to assess a patient and come up with the differential. But first you want to look for signs and symptoms of hypoperfusion, like I mentioned. And then the first thing you want to assess is whether they have high or low cardiac output, also termed warm or cold shock. So if a patient has high cardiac output or warm shock, they're likely distributive. So you want to think of sepsis, pancreatitis, anaphylaxis, adrenal crisis, thyroid storm, or neurogenic shock. In a patient with cold shock or low cardiac output shock, you want to then assess whether they're hyper or hypovolemic, so termed either wet or dry shock. So in wet shock, that's usually with cardiogenic, so you want to look for risk factors from MI, heart failure, valvular disease, arrhythmias, or myocarditis. And then in dry shock, you can actually see this both in hypovolemic and obstructive shock. And you want to keep in mind in hypovolemic shock, you can both have pure hypovolemic shock, like an extensive burns, or hemorrhagic shock. And then obstructive shock, that's commonly seen with like PEs, pneumothorax, and tamponade. So you want to look for risk factors for hypercoagulability. Do they have bilateral breath sounds? Maybe assess for JVD or pulsus paradoxus. So this is just a little summary of the types of shock and then their management styles. So we have our warm and dry shock, which is our distributive, mainly fluids and pressors if needed, and then management really depends on the type of shock. Then you have your cold and wet shock, which is your cardiogenic shock, inotropes and diuresis, and then whether they have an arrhythmia, consider cardioversion or pacing. And then here is our cold and dry shocks, our obstructive and hypovolemic. Obstructive depends on the reason for shock as well, and then hypovolemic, fluids, blood products, and source control. So it was actually recent updates on the Surviving Sepsis campaign that just came out this past October, just a few months ago. And these are updates on the 2016 guidelines. But one of the biggest discussed update is that they downgraded the recommendation of a fluid resuscitation of 30 cc's per kilogram per hour within the first 3 hours from a strong recommendation to a weak recommendation with low quality of evidence. And that's because optimal resuscitation really depends on the individual. So we want to give fluids to restore perfusion, but we don't want to push them over the edge and then worsen end organ damage or end organ function. And both limited and large amount of fluids have been associated with poor outcomes. And interestingly, actually the best response was seen with 15 to 45 cc's per kilogram, but that's just too wide of a parameter to be used for clinical practice. And then they've seen an association between positive fluid balance in the ICU and poor outcomes. And a really important study called the Andromeda study actually showed that half of patients with septic shock were fluid responsive, and the patients that initially responded to the fluids became rapidly non-responsive. So you can see this is from 0 to 8 hours of fluid resuscitation, and the dark blue area is patients that are responders to fluids, and you can see it rapidly declines within the first few hours of resuscitation. So keeping that in mind, then what are the goals of fluid resuscitation? So you always want to keep in mind the initial indicators of hyperperfusion that you noted and see if they're improving, look at the vitals, the urine output, and the mentation. Always remember that dynamic variables over static variables. So is the variation you saw in the IVC or the pulse pressure improving? Often we use lactate clearance as a goal of resuscitation, but you always want to keep in mind, is the lactate continuing to respond? And do they have other reasons of why they would have a high lactate? So I had a patient in the ICU that had a very large necrotic malignant mass, came in with sepsis with a high lactate, and their lactate downtrended with fluids and then plateaued. So that necrosis is a reason for why she would have a high lactate, and likely she's not going to respond to further fluid resuscitation. I also put mixed venous oxygen saturation here just because it was commonly used previously and the goal is greater than 70%. But just keep in mind that this is a static variable, not really used as much in practice anymore, and that there's better, less invasive ways of predicting fluid responsiveness. The other updates, initially it was either balanced crystalloids or saline for resuscitation, but now they're only recommending balanced crystalloids like LR. That's because there's adverse effects with saline like hyperchloremic metabolic acidosis. And also the SMART trial in 2018 showed a lower 30-day mortality with crystalloids over saline. They also emphasize starting peripheral pressors immediately to restore mean arterial pressure rather than delaying pressors while placing a central venous access. And that's because peripheral pressors are generally safe if less than 6 hours, particularly if it's given distal to the antecubital fossa. And the last update was that there's a stronger push for using IV corticosteroids as an adjunct in septic shock for patients with ongoing pressor requirements. And the reason why corticosteroids are helpful in sepsis is because sepsis is associated with a dysregulated response of the hypothalamic pituitary adrenal crisis, essentially meaning that adrenal insufficiency may be contributing to the shock. And there's been 2 large trials that have come out since the 2016 Surviving Sepsis Guidelines, the last one, that have really furthered the debate on utilizing corticosteroids. So the first one is they used both hydrocortisone and fludrocortisone together against placebo and septic shock patients requiring high-dose vasopressors for at least 6 hours. And they actually saw a lower 90-day mortality in the steroid group. And then the adrenal trial, they only looked at hydrocortisone versus placebo, also in septic shock patients, but receiving any pressors for at least 6 hours. They saw a similar 90-day mortality, which is opposed to the first trial, but fewer days on the vent in a faster resolution of shock. But to keep in mind, they didn't take into account recurrence onto the vent, just coming off the initial intubation. But because of these trials, there's more talk about using corticosteroids, and that if you are going to add high-dose stress dose steroids, you should consider also adding fludrocortisone. And then last topic is on pressors. So just to go over some terminology, vasopressors, they act by increasing systemic vascular resistance. Inotropes, they increase cardiac contractility and heart rate. And inodilators, they decrease systemic vascular resistance. So this was a great table. Shout out to Jordan Abrams from the anesthesiology department, who actually made a lot of great ICU infographics, including this table, which you can probably access through your emails. But just to go over kind of the key points, first we have levo or norepinephrine. So that predominantly acts on the alpha, but also on the beta. So predominantly increases systemic vascular resistance, but it's also inotropic. It's the most widely used pressor. It's first line in both septic and hypovolemic shock. The max dose is 30 mics, but once you get to 10 to 15, that's when you want to consider adding a second vasopressor, which is usually vasopressin. And then if you ever have increased systemic vascular resistance, you always want to look for peripheral ischemia, and anything that has inotropic effects, you want to look for arrhythmias. So then we have vasopressin, which similarly affects systemic vascular resistance, but also increases renal water retention. Like I said, it's the second pressor added, but it's given at a fixed dose, so it doesn't have that many side effects. Epinephrine at low doses acts on beta, and at high doses it acts on alpha. So predominantly inotropic, but also increases systemic vascular resistance. And because of the inotropic effects, we can use it for symptomatic bradycardia. We can give it in pushes to stimulate the heart during ACLS. It also stabilizes mast cells, so used in anaphylaxis and just a general adjunct in shock. Its max dose is 40 mics. Because of the predominantly inotropic effects, you want to look out for tachyarrhythmias. And an important thing to note for epi is it actually elevates our lactate. So if you're using that as a goal of resuscitation, it's something to keep in mind. And it's not from hypoperfusion, it's actually an aerobic mechanism. Then there's phenylephrine, which is the only one that's a pure vasopressor, so only systemic vascular resistance and only alpha receptors. One thing that's cool about this is that when it increases systemic vascular resistance and blood pressure, it actually causes a reflex bradycardia. So oftentimes you can use this pressor. For example, if a patient has like persistent AFib with RVR, difficult to control, you can put them on this pressor that might help utilizing that bradycardia. And then we have dopamine. So dopamine acts on all the receptors. So it's kind of difficult to use. It's kind of known as a dirty drug, if that helps you remember it. But it increases renal blood flow and urine output. So it's difficult to use that as a goal of resuscitation. It had been used for refractory shock, but there's actually increased mortality of dopamine compared to levo. So it's just not really utilized anymore. And lastly, these are the inodilators. So dobutamine and milrinone, which are both used for cardiogenic shock. So dobutamine predominantly acts on beta. It actually has very little alpha activity. And milrinone, it inhibits adenyl cyclase and increases cyclic AMP. But just essentially, both of them are inotropic and they're inodilators, so they decrease systemic vascular resistance. So dobutamine is given at a max dose of 20, and milrinone, you have an initial loading dose and then an infusion. But essentially, milrinone has more of a vasodilatory effect, so it's actually more effective for cardiogenic shock, but it's more difficult to titrate, and it's also renally excreted, so you can't use in renal failure, so that's why we often see dobutamine. And the other thing to keep in mind is the effect of blood pressure. So really with the inotropic effect, if your heart responds well to it, you will see an increase in blood pressure. But if your heart doesn't respond well because it doesn't have much ways to go, you'll just have that decreased systemic vascular resistance. So you can actually see a decrease in blood pressure. So just something to keep in mind with those drugs. And so just to summarize about shock, the pathophysiology, it's an imbalance of oxygen demand and delivery. And who we see, it really depends on the kind of shock. So sepsis, think about immunocompromised patients. Maybe they have indwelling devices. With obstructive shock, look for signs of hypercoagulability, maybe COPD or connective tissue disease if they have a pneumo. For cardiogenic shock, look for a history of heart failure or MI, and hypovolemic shock, maybe history of trauma, burns, or an acute GI bleed. Always look for signs of hypoperfusion, and if they have that, assess for high and low cardiac output and hyper and hypovolemia to help differentiate the shock. And then in terms of treatment, it's really based on the type of shock. You always want to assess if the patient is going to be fluid responsive, and if so, what are your goals for fluid resuscitation? Keep in mind the vasopressors, inotropes, and inodilators. And then if you are going to add stress dose steroids, consider also adding fludrocortisone along with that.